Hey everyone, and welcome to this explainer. If you're an MBBS student, you're in exactly the right place today because we are going to build a complete mental map of pain physiology. We'll trace the incredible journey of a pain signal, starting literally right at the peripheral nerve endings, traveling all the way up through the spinal cord and finally arriving at the brain. And after that, we'll look at how the body, and how we, using modern medicine, can actually step in to create pharmacological relief. Okay, we've got a lot of ground to cover, so let's dive right in.
Here is our syllabus roadmap for the session. We'll cover the nature of pain, receptors and pathways, classifying pain types, referred and phantom pain, endogenous inhibition, and wrap up with pharmacological pain management.
All right, let's kick things off with Section 1, the nature of pain, understanding our body's ultimate alarm system.
So, first things first, there is a very clear distinction made by the International Association for the Study of Pain. They define pain as an unpleasant sensory and emotional experience. Nociception, on the other hand, that's just the unconscious activity induced by a harmful stimulus applied to your sense receptors. It is absolutely crucial to remember the difference here. Nociception is just the biological wiring firing, but pain is the complex, emotional alarm bell that's actually ringing in the brain.
Now, the famous English neurophysiologist Sir Charles Sherrington called pain the physical adjunct of an imperative protective reflex, which is a fancy way of saying, while literally no one likes being in pain, it acts as a critical evolutionary survival tool. It warns the body that something is seriously wrong and immediately initiates potent withdrawal responses. Think about it. If you touch a hot stove, pain is what instantly preempts all your other sensory signals and forces you to yank your hand back before you get severely burned. It's a lifesaver.
Moving right along to Section 2, receptors and nerve pathways. Let's trace that signal from the source.
Have you ever noticed that we actually experience two distinct waves of pain? It's fascinating, and it brilliantly illustrates how our peripheral nerves are classified. First, we have what's called fast pain, and this is mediated by lightly myelinated A-delta fibers. This is that sharp, precisely localized sensation you get instantly from, say, a pinprick. But that is almost always quickly followed by slow pain, which is carried by unmyelinated C fibers. Slow pain is that dull, intense, diffuse, and just incredibly unpleasant ache. So, when you accidentally smash your thumb with a hammer, that immediate sharp spike is your A-delta fibers firing off, followed a second later by the throbbing, agonizing ache mediated by your slow C fibers.
Now, visually anchoring this, the anterolateral system, and specifically the ventrolateral spinothalamic tract, is your primary highway for pain and temperature. Notice how the fibers enter the spinal cord and then they immediately decussate or cross over to the other side before ascending up to the thalamus. Keep this in mind because it's a huge anatomical landmark you're going to need for your neurology clinical rotations.
So breaking it down, it's a classic three-step journey. First-order neurons, the nociceptors, pick up the signal and take it to the dorsal horn of the spinal cord. Then, second-order neurons cross over and travel up to the thalamus. Finally, third-order neurons project out to two main places: the primary somatosensory cortex, so you can physically locate where the pain is coming from, and the limbic system, which processes all the emotional misery of feeling that pain. This exact structure perfectly explains why a lesion in the spinal thalamic tract causes a loss of pain and temperature sensation on the opposite side of the body, below the level of the injury.
Okay, Section 3, classifying pain types, the difference between acute and chronic.
At the bedside, we generally divide pain into acute and chronic. Acute, or physiologic pain, is essentially the good pain, right? It has a sudden onset, it actively protects you, and it fades away as the tissue heals. Chronic, or pathologic pain, on the other hand, is the bad pain. This is pain that persists long after the tissue has physically healed. We're talking inflammatory or neuropathic conditions, like diabetic neuropathy, and it is notoriously frustrating to treat because it frequently just doesn't respond well to standard NSAIDs or opioids. When a patient has chronic pain, it often means their central nociceptive pathways have actually structurally reorganized themselves. And when those pathways reorganize, you're going to see patients experiencing two very specific, very difficult phenomena: hyperalgesia and allodynia. Hyperalgesia is basically an exaggerated response to something that really should only hurt a little bit. But allodynia, that one is deeply fascinating and honestly tragic for the patient. It's a sensation of pain in response to a normally completely innocuous, painless stimulus. You are absolutely going to see allodynia on the wards when a patient with severe neuropathy winces in pure agony just from a soft hospital bedsheet brushing lightly against their leg.
That brings us to Section 4, referred and phantom pain. Let's look at some crucial bedside clinical correlations.
So, have you ever wondered why a patient suffering from cardiac ischemia, a heart attack, often feels severe pain radiating down their left arm? Deep, visceral pain from your organs is very different from superficial skin pain. It's poorly localized. It causes nausea, often sweating. And because of this incredibly poor localization, the brain actually gets a bit confused, leading to the phenomenon we call referred pain.
The convergence projection theory explains this perfectly. Somatic pain fibers from the skin and visceral pain fibers from deep internal organs actually converge on the exact same second-order neurons right there in the spinal cord's dorsal horn. Now, your brain is way more used to receiving sensory signals from the skin than it is from the heart. Because the heart and the left arm develop from the exact same embryonic dermatum segment, the brain just misinterprets that cardiac distress as trauma happening to the left arm. It's a literal crossed wire.
And then we have conditions like phantom limb pain and causalgia. Causalgia is a spontaneous, intense burning pain that occurs long after a seemingly trivial peripheral nerve injury. In these extreme neuropathic conditions, the pain pathway itself is what's diseased. Microglia in the spinal cord can actually activate, releasing inflammatory cytokines that essentially short-circuit the pathways. This results in an excruciating condition that's happening completely in the absence of any actual physical nociceptor discharge. All right, Section 5, Endogenous Pain Inhibition. This is where we talk about the body's natural blockers. Let's look at the gate control theory of pain, because this is a game changer. In the dorsal horn of your spinal cord, specifically at laminae 2 and 3, which is also known as the substantia gelatinosa, there is a sort of neurochemical gate. When you experience pain, your slow pain fibers are trying to push that gate wide open to send the signal up. But if you stimulate the large, fast A-beta touch fibers, they can actually override the whole system and swing the gate shut, actively blocking the pain transmission. This theory brilliantly illustrates why when you bang your shin on a coffee table, your first instinct is to immediately and aggressively rub it. That tactile sensory input from rubbing literally closes the gate on the pain signals right at the spinal level.
But wait, it doesn't just happen at the spinal cord level. The brain can also command pain to stop from the top down. This is the descending pain inhibitory pathway. It starts up in the periaqueductal gray, or PAG, in the midbrain. From there, it triggers serotonergic neurons in the nucleus raphe magnus and catecholaminergic neurons in the medulla. These neurons then project all the way back down to the spinal dorsal horn to inhibit those incoming pain signals right where they enter. Basically, it's the brain's way of sending a massive stop signal to intercept the ascending pain messages before they even fully register.
And driving a huge part of this top-down descending inhibition are our endogenous brain opioids. These are, for all intents and purposes, our body's internal, built-in painkillers. They modulate pain transmission by binding directly to receptors throughout the periaqueductal gray, the brainstem, and down in the dorsal root ganglia. Now this is key. These endogenous opioids are the exact physiological targets that the medicinal opioid drugs we prescribe attempt to mimic and hijack.
Which leads us perfectly into Section 6, Pharmacological Pain Management. How we go about hacking these pathways. Look, I know that as an MBBS student, memorizing massive pharmacology drug lists can be pretty tedious, but by tying the specific drug directly to its ionic channel or receptor, you can quickly see how pharmacology is essentially just applied physiology. We know NSAIDs block inflammatory prostaglandins, and opioids hit those opioid receptors we just talked about, which is great for acute pain, but as we saw, they often fail in chronic scenarios. Look at capsaicin patches. They literally exhaust the nerve supply of substance P and act on TRPV1 receptors. Lidocaine blocks NV1.8 sodium channels, which are uniquely associated with nociceptive neurons. Ziconide blocks N-type calcium channels for severe refractory pain. And gabapentin, which was actually originally an anticonvulsant, blocks voltage-gated calcium channels to treat neuropathic pain. Every single drug on this list maps to a precise physiological target on the exact neural pathways we just mapped out. So, as we wrap up, I want to leave you with something to chew on. Right now, roughly 10 to 20% of the global population suffers from some form of chronic pain. The current treatments we have often just aren't enough, and obviously, opioid addiction is a massive, ongoing crisis. As you step out of the classroom and onto the clinical wards, I want you to remember that chronic pain is an immensely complex, reorganized neural state, often involving that activation of microglia and deep neuroinflammation. How will your generation of physicians use a deeper, more nuanced understanding of these precise neuropathic pathways to develop the next wave of targeted, non-addictive treatments? Mastering the physiology of pain today isn't just about passing an exam. It's your very first step toward truly healing your future patients tomorrow.
Thanks so much for joining me on this explainer.